turnout for this particular session, and it gives me great pleasure to have the opportunity to introduce both of our speakers to you. I promised them I wouldn't read verbatim from their very, very prestigious and interesting biographies, and they asked me to make things up about them. But I don't feel I know these two gentlemen well enough to take a stab at that. So if they want to add anything to my more mundane remarks, they can certainly do so. Allow me to start by introducing you to Craig Schneider, the gentleman on the left, and Craig is going to be our first of the two speakers. I do want you to know, even if he thinks it's boring, that Craig is the managing director at Impact International, and he is a leader in promoting accountable care, developing and implementing payment systems for reform strategies, and engaging stakeholders across the healthcare system. Why? In order to improve consumer engagement, efficiency, and quality. Craig. The gentleman to his right is John Minichiello, and John is the executive director of Integra Community Health Care Network in Rhode Island. Integra is a Medicare, Medicaid, and commercial ACO with a total of more than 120,000 covered lives. So my understanding is that Craig's going to kind of set the stage with the big picture, and then he's going to turn it over to John, who has had the focused experience with the ACOs. So I'm going to turn it over to you. Thank you, everybody.
Thanks very much. Oh, okay, we need our slides, don't we? Hang on. One o'clock presentation. Let's hope this is the right guy.
I didn't touch anything, Craig, honest. I barely breathed.
There we go. And now we want switch. Oh, okay. It's where it looks different on my screen than the slides. Okay, great. Sorry about that little delay there. Hi, you've just heard my introduction and brief biography of the kind of things I've done in my career. Since it's topical, I usually don't mention this, but Molly wanted our biographies to be entertaining. So I will tell you a fact about me that not many people know, but it's been in the news so much lately. I was on Jeopardy! Yeah, that's what you know, yeah. Who was watching October 1996? Raise your hand. But yeah, that was a great experience. You want to ask me afterwards, happy to chat about that, but that's not what we're here for today.
How well you did, though.
What?
How long were you on?
Okay, I did not do as well as James. I won once, and back then the money was half, so I won $12,600, so that would be like $25,000 today. So that was fun. Okay, so switching back to the reason you're here today. And so I thought Dr. Ryder's keynote presentation this morning was awesome. And he said something that definitely relates to this topic of social determinants, is that the key to improved healthcare is social care. And so that's really what we're going to be talking about. And another thing that, connected from this morning is I was walking through the exhibit tables and I had a chat with some wonderful ladies from the area agencies on aging. And they said, oh, we've been doing social determinants, forever. That's what we do. So I'll give a shout out to them. I think what we're talking about is that Medicare and Medicaid as well in this particular model are now getting into this game. So it's not that social determinants of health never existed, no one ever thought about it. It's that, that Medicare and Medicaid are now participating in this space, and we'll talk a little bit about what that means. So, okay. So my screen and what you're seeing aren't the same. Okay, so just a little bit of background, and really I do just want to set the stage, because I think John's presentation is going to be more like, what is this happening on the ground, and how are people actually being helped? And that's what we want to hear about. But I want to do some level setting. So the first thing to learn about is this Center for Medicare and Medicaid Innovation. Let's see, does this work? There we go. Okay, so the Center for Medicare and Medicaid Innovation is a part of the Centers for Medicare and Medicaid Services. I was at the agency way back when it changed its name. It used to be called Healthcare Financing Administration. Who remembers that? And like, Healthcare Financing Administration, what the heck do they do? Centers for Medicare and Medicaid Services. Oh, okay, now I know what the heck they do. And so, as part of the Affordable Care Act of 2010, this Innovation Center was established. And the Innovation Center itself is, as controversial as the ACA was, the Innovation Center was pretty much bipartisan, nonpartisan, because what is it about? It's about improving quality and lowering costs and making care more patient-centered. That's kind of apple pie stuff that everyone can get on board. Now, how you do it, people might have different views, but those overall goals and principles are pretty universal. And so what the Innovation Center does, the very first thing they did is said, send us your good ideas. The very first model they launched is called the Innovation Awards. And they got, if my math is right, something like 900 applications for, hey, we have this great project idea. And that was so big, they did a second round of those. And then over time, they started rolling out something like 50 different new kinds of payment models. So what we're going to talk about today, the accountable health communities, is one of those 50 whatever payment models. So why did CMMI say, okay, here's something that we want to get behind and invest in and devote some resources to? It's because there's a recognition that many of the drivers of healthcare costs happen outside of the clinical care setting. And we'll see a graphic soon that illustrates this, that things beyond the clinical condition that a patient has at a particular point in time are driving utilization and costs, like their housing situation, their family situation, things like that. And there was emerging evidence at this time, we're rolling the clock back 5 or so years, that addressing health-related social needs. So that's the term of art in this model. Often we'll say social determinants of health. For the purpose of this conversation, think of that interchangeably with health-related social needs, or HRSNs. So that if you link what's happening in the clinical setting with the community resources to address those needs, then that will improve patients' health status and slow the growth of costs. Okay, and so here's that diagram I mentioned. So generally, is this not advancing? Ugh. Why is it not moving down? So I can see the graphic that I'm talking about.
You've got help in the back, right?
So I want to be showing slide 4 at the moment, if that's helpful. Oh, okay, great. Sorry about that.
Maybe it's not on slideshow.
Yeah, let's try that. Oh, resume, okay. Ah, there we go. Thank you, good tip. All right, so generally, when we're thinking about healthcare, right, we're talking about this piece right there. And it turns out that that's only 10% of what's going on. And the social determinants of health, the health-related social needs, add up to 60% of what's driving costs and utilization. So that, and that's a very different way of thinking about things than the healthcare system has been thinking about historically. Okay. Why is this thing not being nice to me today? Okay. I'm going to go to my hard copy. So, all right. So they created, in response to that, so this is not the right slide, but I'll get there in a minute. In response to recognizing this evidence that a factor, a 6-time more important factor, this addressing the social determinants. Are you on slideshow right? Yeah, I want to be on this slide right now. Yeah. So it's not right, the arrows aren't working right. Okay, we'll just plow through, and sorry about that. So they created the accountable health communities model and had allocated over a 5-year period, which started about 2 years ago, $157 million. So remember I said they want to think, where to deploy resources to invest. This is serious resources that they're investing. And this is the first innovation center model that is testing building a community capacity to address the needs of beneficiaries in a specific geographic area. And so what they're doing is screening people who live in the community to identify these unmet health-related social needs. And then, once these needs are identified, refer them to increase awareness of the services, to help navigate through this network of community service providers, and then ultimately to align the clinical setting with these community resources. And I want to make one point here because I said, the Innovation Center thought this would be a good idea, but it's really important to understand that this is revolutionary for Medicare. It's a big change for Medicaid as well, but to an even greater extent for the Medicare program. The fundamental piece of Medicare law dating back to 1965 is that services be medically necessary. So that sounds like a wonderful thing, right? People shouldn't get services that aren't necessary, and it's a way to prevent fraud and abuse. So, right, medically necessary is an important component, but when you say medically necessary, that means that people operating in the program do not have the ability to bill for things beyond medical care. So, the classic example of this, which is not a Medicare example, but it's good for illustrating, is thinking of a child with asthma who lives in a house, a room with, dust and mites and things that inhibit her breathing ability. And if you just spend $100 on an air conditioner, you can eliminate 3 emergency room visits, right? But under traditional Medicare rules, you can't do that. You need to change this payment system to move to what we call value-based care to enable the providers to invest in those kind of non-medical resources that would actually lower medical costs. So, is it working now?
Which slide are you supposed to do?
Okay. That one, that one.
Somebody changed the display on this computer. This is not the
Okay, you thought it was me. Maybe it wasn't. Okay, so what CMS did to implement this model is they created something called bridge organizations. Can people hear me if I'm a little bit away from the mic? So these bridge organizations could actually be a variety of things. They could be clinical organizations, they could be academic institutions, they could be community-based organizations. So they came up with this term, it's actually kind of a nice term, thanks a lot, called bridge organizations. And so that's who's connecting the clinical sites to the various community service providers that could address patients' health-related social needs. And we're actually lucky in southern New England, 3 of those organizations are here, and we're going to hear from one of them shortly. So these organizations identify and then partner with these with the clinical delivery sites, then they conduct screenings and make referrals to the community organizations. And here's a little map, and you can see, here's our 3 Southern New England organizations. We're pretty well represented, given that there's only 30 across the country. And so this is getting a little in the weeds, but just the way the model is designed is that there are the 2 tracks, quote, assistance track and alignment track. So I won't go into all the details, but the organizations could choose which one of the tracks they wanted to sign up for. And then here are the interventions that they do. For the assistance track, they take an inventory of what's available to help people. And then they conduct this screening of anyone who comes in to the office. And then once someone screens positive for one of these health-related social needs, then they get the referral to the community services. And then they help them navigate to figure out what could help meet their needs. Now, the alignment track does everything that the assistant track does, but it also has an advisory board to ensure that services are provided appropriately and that there's adequate capacity and that the data is flowing effectively. So the screening tool, and I was fairly involved in this, the screening tool was developed by a technical expert panel. That was before I became involved. But then my team at my previous employer tested the screening tool with real live beneficiaries. And then we made recommendations to the agency about how to modify the language, the way the questions were structured, just so that people could really understand what was being asked and then give the appropriate responses. And so every bridge organization must address these what are called core HRSNs: housing, food insecurity, transportation. All right, those will sound pretty similar to the list Dr. Ryder discussed this morning, right? Also help paying for utilities and what they call interpersonal safety. If that term doesn't resonate with you, it's really about domestic violence and identifying that and again, making the appropriate referrals. There is also a whole list of what they call supplemental needs. And so bridge organizations could choose to also screen for and refer and navigate to these supplemental needs. And so again, it was up to each bridge organization to decide which of these they wanted to include in their program, subject to approval by Medicare and Medicaid. Okay, so now if you're one of these bridge organizations, at least, during the year or so that I worked with them, I observed 3 kind of key challenges. One is like, how do you actually conduct this screening, right? Because as implied by that list of things, and as Dr. Ryder mentioned specifically, like there is shame and stigma associated with these, and with the interpersonal safety, there's literal safety threats. If your abuser overhears you reporting abuse, like that's a real concern. So how do you do this screening in a confidential way that protects and respects the patients? And think about from the organization, the staff perspective, like what kind of training do people need to do this screening sensitively and appropriately? So that's a challenge. The second is there are data collection and reporting requirements that are challenging, and there's as I indicated, there's a whole range of these bridge organizations. So there was different capacity in how they created and established their data systems. And then the third thing is like, well, who are these community partners? And who are they? How do I know that they're going to do a good job? Like that is a big challenge in establishing this system. So that's kind of the overview of the model, and now we're delighted to have a real-life example of a bridge organization that'll talk about the experience in implementing this program. And here's my contact information, and thank you very much.
Okay. So thank you for all attending, inviting me. I was not on Jeopardy. It was the
Wheel of Fortune.
not in Wheel of Fortune. It was the D in geography in 7th grade that kept me from that. Delighted to be here. I think Craig did a nice job, and you can see why he did so well under pressure in Jeopardy, dealing with the. But at the end of the day, this was resources from CMS to our organization to do some screening and do some navigation. So I'll talk you through some of that. I can't give you all the inside, as it's an ongoing research project, and quite frankly, a lot of it's embargoed still. But as Craig said, it's a real hot topic, and I'm not even sure everyone's even aware it's ongoing. There's probably 30 of us, throughout the country, and we were fortunate. And quite frankly, when we entertained this, and this was actually before I got there, and I'll give you a little background on the organization in a minute. We didn't know what we were doing. It just sounded like the right thing at the right time. Certainly an ACO has a whole host of responsibility, but to enable us to actually go into this just seemed like we had to do it. And in hindsight, there was no playbook. Even CMS is still trying to figure out along with us. So a lot of pressure, but truly I think we're figuring this out as we go along. We're about 2 years in. The first year actually was a planning year, so you can only imagine what that was like. And the second year was more of an execution, if you will, and we're going into year 3. So just to put it in the context, so Integra Community Healthcare is a ACO in Rhode Island. Very interesting market in that it's a small market. We probably have more than 10% of the population enrolled just in our ACO, which is kind of neat. You can navigate it. It's very intimate. We have very close relationships with other systems of care, employers, elected officials, et cetera. So it's a nice testing ground, I think, to try to accomplish a lot in a little space. That being said, everything I see now about social determinants, and it's at first I reacted like everyone else did. Here we go. We have another acronym, and shout out to Homer Simpson on that one. One of the things, though, I think that we have to differentiate between is that social need, and truly the social determinants in the community could be unemployment rate versus, the interactions we're having with individuals right now. We may work with an individual that's unemployed, but that's a whole nother layer to actually get to the community and actually get to the true determinants of health in that community. So community is a huge piece of this. I'm not trying to downplay it, but truly I think the progress we're making right now is kind of the mechanics, the education around this, the understanding of what we're trying to do. I wouldn't quite say in a year and a half we're even in any position yet to make a huge sweeping change in really the culture and the from a legislative perspective, as well as just really the way that the communities are resourced to even provide these services. So that's a little bit of a caveat. I'm not a pessimist, I'm more a pragmatist on this one. The other thing I just want to point out is some of the literature, as Craig had said, groups have been doing this for a long time in one form or another. Community health centers, of course. Montefiore is a real big organization that's been doing some of this. So my perspective, our perspective is an ACO that's very heterogeneous. We've got 160 practices that do things 160 different ways. So this isn't something where we can just drop into a multi-specialty practice and change a workflow. And truly, a lot of this comes down to the workflow and the ability to somehow integrate this, resource this, and really educate the community in terms of what we're even trying to do. On a personal note, it's interesting. My last physical, I was asked some of these questions, and quite frankly, it threw me for a loop. In 25 years of seeing my provider, no one had even asked these questions to me. So that in and of itself, I think, is one of the challenges. Another issue I just want to, before I get into a little more specifics, is that the way we resource this, CMS is, the anecdote that we use is, sure, there's millions of dollars being poured into this, and to a certain extent, it's what we need to do, of course, but what we like to say is we can't even buy a man a sandwich. So these resources aren't to build capacity in the community. These resources aren't to somehow, some way connect patients necessarily. It's more screening and then navigating to existing resources. So one of the challenges we know that we have and that we will continue to have is a waiting list. Because if we ask these questions about housing, I don't have an answer for housing. We've got some resources in the community that can help with that, but how quickly are we putting a line in place for those to be addressed? So I just want to put that caveat in there as well. And I think a lot of this, what's a middle-aged white guy executive trying to do in community health? I think a lot of that and a lot of this research or whatever we're doing in a laboratory is actually to break that silo down. There's nothing more important to the community coming into my boardroom and for myself to get into the community. We have a tremendous amount of work to do, but even just breaking down that silo for me has been hugely educational. There's no way that we're going to dictate. The community needs to tell us what we need, but we want to be a catalyst to help them get that. And then you may have also heard former Congressman Bill Cassidy, now Senator Bill Cassidy, has said, and I think he put it well, prosperity is the key to improving health outcomes. So, that is a much, much, much bigger endeavor. And I can't quite figure out that one in the perspective of what we're trying to do. But let's talk about it. So first of all, I think there's startup resources. So we were fortunate enough to earn this grant, and now we have some startup resources. So that involves hiring people to do some of this work. Sure, we can co-opt some of the people in the practices, but let's face it, who in their medical practice right now believes they have added capacity to do any of this work? Even if there might be some, I just don't think, it's an inertia that we're trying to go through. And our ability to change those workflows too, right? How difficult is that? Because you really need to unlock and then change and then lock in again. So we've done a little bit of both. We've tried to integrate into some existing workflows. That has been tremendously challenging. And then we've also supplemented it with community health workers. And in hindsight, we were thrilled to bring community health workers into our organization because historically we haven't been focused in that way, not because we don't believe in it, but typically ACOs start, and we're 5 years in, start with keeping patients out of the hospital. That's typically what we do, and that could be coordination of care, care management, disease management, and all such. Now, obviously, we're starting to realize the benefits of community health work and working in the community. However, we did go the community health worker route, and I think what we learned is we don't necessarily need them to do screening like everything else, top of license and trying to work through. And quite frankly, the screening piece is tremendously difficult, as was mentioned. And what's interesting is, there's so many technological options, and I'll talk about that in a minute too. Some of this is very private. You need space for privacy. In some cases, patients that have answered surveys, they'd rather write it down and hand it in than be face-to-face. So it can be a very, very personal discussion, as I'm sure you're all aware of. And we've struggled with that. We've struggled with trying to figure out the right mix, the right way to ask the questions. Initially, we thought it would be 3, 5, 7 minutes. That's ridiculous. I mean, if you think of what we're trying to actually do and the way we're trying to actually help folks, let's not just add it to the hurried 10-minute visit, that we're already trying to ask quality outcomes be done, preventative screening, and now let's throw this on top of it. So that's where I'm a little pessimistic, but I think it's still the right thing to do because we're trying to figure this out. So this is very much, how do we figure this out? So without the infrastructure, I'll be totally blunt, the ACO probably wouldn't have jumped into this. I need to figure out the return on investment. The return on investment on this could be multiple years. We also need to make sure that the patients we're caring for today continue to be in our ACO 6, 9, 2 months, 3 years from now. And as many of you who are in that space may or may not realize, that's a tremendously difficult thing to do because the attribution and everything else, patients cycle in and out. So if you really think about that, if I'm looking at a 3 to 5 year time frame and I'm deploying resources right now, I've got I have to be tremendously patient. So that's something to think about. I think the other thing, too, with the resource piece is how do we quantify the resources we're adding to this? So sure, there's a labor component of that in terms of supplementing who can help us with this work. But what's the value of a basket of food? What's the value of some of the dialogue that we have with some of the patients regarding housing? If and when those community service organizations engage these patients, how do they quantify exactly the time and the energy and the resources they put into that? So any good ROI calculation is inputs, outputs, and then you do that calculation. We're still trying to figure out exactly how to quantify the inputs. So not something that's readily available yet. As I said, we're still trying to figure out how to do this. The provider workflow in a perfect world for us would have been to embed this in every delivery site that we want to entertain this survey and just make it common practice. But as I said, we're throwing this on top of already a harried environment. One would think the EHRs can accommodate this. That's a whole nother work in process. Right now, there are a lot of third-party vendors where we can bolt on. Okay, there's some functionality there, but then now you're out of your little ecosystem and off in another system, log into another system, et cetera, et cetera. So there's definitely challenges with workflow. The screening tools, you can Google the screening tools. That is pretty much, that ship has sailed. I think the trickiest part, though, is trying to figure out, and Montefiori's done a nice job with this, they actually do some upfront screening just on stress and stressors before they even dive into something as specific as, do you know where your food pantry is? And in hindsight, that would have been something we definitely would have entertained. We are working under very strict operating procedures, though. One of the challenges in this is that we can't always move on the fly. What's interesting is when we thought of this project years ago and where we are today, it's night and day, if you really think about what's happened in the last 2 years around social determinants. So it's a little tricky for us because we actually already see where we should be just based on the experience of where we're at. And the challenge for us is actually trying to get there within the confines of this program. So that's very interesting. The community outreach has been phenomenal. There's nothing more satisfying than trying to bring in the community benefit organizations. But I will tell you that once you do, and I respect this, their question to you will be, well, what do you bring to the table? Do you bring any resources? No. We bring more referrals. Well, that isn't always that welcomed in some of the organizations that are already at capacity and are constrained. But it's opened the dialogue. It's opened the dialogue of what's going on in the community. What we've found is many of these resources are underutilized, which is phenomenal to think that we're promoting at least that. But that's a struggle. I would have liked to have come to the table and said, participate with us, and maybe we'll triple your capacity in 3 years. The model's not there, the financing is not there. We're just not at that point, but that could be where we go. A couple other things on really sustainability. That has been one of my biggest concerns. This is great, it's helpful, we're providing help, but where does this go? And the challenge of us not now leaving behind the community if the funding runs out. And that's been a real difficult conversation to have, because the more we get into this, and then if the funding runs out for whatever reason and we can't support it, then what? So sustainability is huge. I think scope and scale is also. I would caution you to do as many pilots as you can. This is not one of those things where you can just literally say, okay, here's where we're going to do it. Let's choose the 50 practices or the 30 delivery sites and just roll it out. Just doesn't work that well, I think, going in that direction. So scale and scope are tremendously challenging as well. And then I think at the end of the day, there's a process and an outcome. So we have created a process. It is still very early on to figure out at the end of the day the outcome. And one of the other challenges with this is, and this isn't a criticism, it's just a constraint, is when we navigate patients. So if we have a community health worker navigating one of these patients, perhaps with a food insecurity, we're really not engaging that patient and then continuously working with that patient. To a certain extent, we need to stop and move on to the next patient. That's the beauty of where the ACO can step in. And that's the beauty, I think, of where we can start doing even more with this, is that we won't necessarily end when they hit the food pantry. We can then work with that patient for the next how long to try to figure out how to really provide the help that they need. But that's not the way it was designed. Again, not a criticism, but if you all think through, the longitudinal way of this approach, that's really the end game. It's not so much just making the connection, but it is what it is. A couple of comments on patients. So, and we've had to force ourselves to call them clients. So this is health, not healthcare. We're actually trying to prevent unnecessary health care. So we see these folks as really clients. One of the things that really intrigues us and continues to intrigue us is how we can impact behavioral change. That, to me, is one of the holy grails. Again, where it's very episodic, and if we connect somebody to a food pantry, that doesn't necessarily mean all the other things from a behavioral health perspective. We do a lot of mediation with client needs, which is great. Again, it's trying to figure out the barriers that they have to seek the resources that exist. That's been a tremendous help. One of the hardest things, though, I think that we struggle with is setting expectations. So now you're being asked, gee, are you having a challenge with housing or food insecurity or something else, or you can't pay your bills? And then people start to open up, and then people have some reciprocal expectation that we're actually going to help them and solve it. Maybe in some cases we do. We turned on someone's heat not that long ago because of a linkage that we made in the community. But it's also managing a very high expectation when you ask that question. Now you're at least expected, hopefully, to try to help them solve that. So that's a challenge for us, and that's a resource constraint. As I said, we can't actually purchase the food for them. So it's a bit of a challenge. The housing, it's on everyone's survey. It's a tremendously complicated issue that's much bigger than anything that we can solve in the next 10 minutes. But certainly from the perspective of ride sharing, that's been a great boon, being able to figure out how to make sure patients get to appointments. However, the only caveat with that is if you look at some of the research and some of the literature, it's not always the transportation why they miss the appointment. There are other things like trust, engagement with their own provider system, and some of that was brought up earlier today. So yes, maybe for those subset of patients that truly didn't make the appointment because of the ride, there's also a subset that actually just blew the appointment off, and there's reasons for that. A couple of things on IT technology. It's interesting. Everything nowadays is, I think we can solve everything with technology. So we live in a great time. Then again, just throwing technology at this, that's not going to solve it. Certainly the tools that we utilize, and even in just the last 6-9 months to a year, we have more technology. We have online tools. We have tools to screen that you can put on an iPad. Data can all be collected very centrally. That's helpful. But you can't just throw a tool or technology on top of this. And as I said, the EHR dilemma, we already have a long list of things the EHRs aren't doing for us. No disrespect. So this is just another challenging area of how to integrate any of this information into the EHR. Where does it belong? Who sees it? Why do they see it? Et cetera, et cetera. So we do feel with community health workers, we have to integrate into the EHR without question the work that they do. But some of that is still yet to be developed. There are codes now for this, ICD-10, there are ways, but there really isn't a lot of payment, right? So sure, maybe you could capture in an EHR some of the services, but EHRs are typically also expected to drop bills. This is yet something else that we have to figure out, is who reimburses it, how, at the end of the day, because right now this is all grant. This is grant. We have no revenue source in any of our payers, any of our scenarios, other than grant. And as I mentioned, the ACO could be could subsidize it, but somehow, some way, I have to figure out what the return on investment is. But that's come, it's come farther in the last year or two in terms of trying to figure out how to document, because that's a big issue. And then finally, I think the community. So I think, this is very much a community collaboration. I see the benefits of this, not so much, how much are we helping people and how I can measure that, as much as we're tracking that. I see it really as breaking down silos. I see it as trying to really address these issues that we've talked about for a long time, and really trying to figure out, how do we do it? This will be a multi-year endeavor to continue to figure out how we do it. I don't think anyone can turnkey, what we're trying to do overnight. I don't think that's possible. And then I think the other thing is, just again, characterizing a lot of these interventions as individual. We've probably outreached to thousands of patients. Maybe we've navigated 600-700. We've made some nice connections, but it still feels very individualized. I don't think the community necessarily, even though we're 2 years in, even fully understands what this is. We've tried to brand it in certain ways. It is constrained, though, that it's by a zip code. It's a Medicare, Medicaid. So think about dropping this into a practice that has a tremendous amount of commercial patients. Then you've got another two-tiered system where you can do something for one but not for the other. So all of the things that we suffer and that are our challenges, and I think that keep us up at night, I think apply to this as well. And a couple other things I just want to add. I think really what we're trying to also do is get the ideas from the community. What I don't want to do is tell the community what the community needs. I want to try to catalyze and figure out what we can do to help meet those needs. So I think at the end of the day, that's been a great side effect of this, is just dragging me into the community, dragging the community into our organization, and collectively talking about these things. Because it's amazing how much we don't know about each other. It's amazing how much we don't know about the benefits that we actually provide. So I think breaking down some of those silos has been very important. And then finally, I think just, bringing the systems of healthcare as a potential leader in this, not a bad idea. Bringing in ACOs, again, not a bad idea. However, we don't have all the solutions. I think my next job might be public office, because quite frankly, I'm not even sure how much we can even solve on our own. I think ultimately it does become, in the hands of the elected officials, the communities, the governors, the cities, the states. This issue of poverty, these are really, really, really big issues that we need to address. But it's nice to see, though, that CMS has put in some resources for us to kick the tires and try to figure out what to do with this. So I'll be happy to take some questions, because I think that usually helps really illuminate what we're trying to do. Thank you. Sure.
How many pilots like those are around the country?
So this project, I think it started with 32. It might be down to 30, formal through CMS. Now, there are examples of groups that are actively doing this now. Montefiore is an example of a big system that does a lot of this work. That's a $4 billion system. And then there are community health centers, and there are places where you probably don't even realize in your own community that have been doing some of this, or they've been integrating it in with the social work services they offer, their care management. So there's a ton of this stuff. I think what this project is trying to accomplish is, can you drop into a community with 180 primary care physicians and do this in some sort of a scale and try to figure out how you can make the biggest impact of it. So that's what makes this a little unique, although each of the organizations is very unique. We do. But what we found is the organizations are so unique, it's really hard to figure out best practice. I have a colleague who works for another organization in another part of the state who literally has to get into a propeller plane and go from one practice to another. That's a pretty tremendous challenge. Unlike myself, 45 minutes back and forth, and I can get to all my practices. So it's a nice distribution, I think, of a lot of different provider systems that are trying to tackle this. And I think we want to get to a best practice, at least from a technical perspective, the screening, the navigating, those pieces. How are the patients receiving this? Some completely refuse it. We've had patients, elderly patients all the time, say they're eating well, and then you ask them what they eat, and it's hot dogs and corn chowder. So it does take a whole nother layer, I think, to really make the impact on health much bigger and beyond this project.
And I would just add one thing to that. So yes, there is this activity going around the country in other settings beyond this particular model, but this part of the model, because it's coming out of the Innovation Center, is a very formal evaluation. And the evaluation at the end of the 5-year period will inform the Secretary of Health and Human Services whether this model should be scaled, expanded to a greater degree, or even possibly formally become part of the Medicare and Medicaid program. So that's also an important distinction between this initiative and other kinds of social determinants of health activity around the country.
Yes.
I may be off base, but can you talk about the intersection of the Medicare Advantage population, risk adjustment factors, and is it complementary or competitive for some of the industrial entities that take over primary care groups and other groups, and their focus on revenue streaming of Medicare Advantage versus social determinant, plowing that money back into programs such as this? Does that make any sense?
There's a lot in that question. But let me make a few points. It's a great question. One, we don't, when we measure, manage, quantify any acuity with any patient right now, we don't integrate social determinants. We look at age, sex, diagnosis, et cetera, et cetera. So that has not yet become part of the formula to even be able to figure out, any kind of a risk adjustment or a zip code adjustment. So that isn't even part of it yet, which, that in and of itself is a great point. Medicare Advantage is still, pretty crude in the way that it determines the budgets that providers have to operate around, and it has not yet entertained anything beyond being sick. So that will also be a great debate and discussion going forward, is at the end of the day, how do the health plans actually move these resources around based on zip code, not necessarily based on the diagnosis of the patient. So it's going to be interesting. Did that answer kind of your question? Think a bit? Yeah, okay. Hi.
Hi, this is all very interesting. I'm thinking you're talking about various sizes of clinical settings taking on this kind of screening. But I know, coming from a field that does this kind of work, that the social resources are limited. So if there's screening that effectively identifies more people that require these,
That's right.
you're going to slam into a wall that people are going to be saying, stop, already for housing, excuse me, for housing, to say to somebody, I remember talking with someone who was sobbing, saying, I can't stay with my mother anymore because she's on Section 8, and she's going to lose her rent. And it wasn't until she could get into a shelter and feel like she had some support, but she had to go through this hell in between where there was nothing.
Right.
So that's a picture of how housing resources work right now.
That's right.
And people have to go through a process to sign up for housing that makes them think they have to go into a shelter, and they don't want to.
Absolutely. So that anxiety is one of the big challenges of this is the waiting list. So if we ask 1,000 patients that typically weren't being asked, and 200 of them have a need, and the community resources can only assist 50. What have we done? What have we accomplished? And in some cases, it's actually more frustrating that they were given hope that we were going to address that need. So, not to minimize this, because it is pretty, it's entrepreneurial to some extent, but I think somewhere, some way, we had to at least start looking at who asks the question, and is it bigger than just those that are asking those questions now, number one. And then once those answers are given, who then navigates that, and what are the resources to navigate that? One of the interesting things with this grant is that you need to couple it with a clinical visit. Now, that's not necessary, but it is what it is. But that in and of itself poses challenges as well. You don't have to necessarily couple this. So what we've been asked to do is do this in the emergency room, do this in the physician practice, do this in the clinic. We have other thoughts that maybe it could work a little differently, but that's just not the way that it's set up at the moment. But that is the biggest concern. We haven't hit that concern yet where the community service folks are pushing back at us and saying, stop the referrals. We can't take on anymore. But that's inevitable. I think that's inevitable. And I actually think you can already foresee that, and you probably should start addressing it before you even begin. We're trying to do that. The ACO, because of the way that we do things, we can do things with transportation. We can do some things. So we're willing to put our money where our mouth is and do some things with transportation. Can we necessarily throw dollars at all the other 12 or 15 things that we survey? That's the challenge.
So I heard you mention transportation, privacy, cost, certainly being barriers to the healthcare delivery for the communities in which you serve. I'm curious how you are using virtual health or technology-enabled healthcare delivery as a way to augment and address some of those barriers?
I think it's definitely an option. I think we're so early in this that our challenge at the moment is to get patients that will actually agree to a screen, which is not always the case. Particularly if you're at a clinic visit, if you're in the emergency room and you have a nail through your hand, you might not be in the mood to go through this kind of survey, even though it could be beneficial. So our challenge right now is literally trying to get patients to open up and then trying to figure out a way we can connect them. We haven't even yet thought of, maybe technology as being another option on the back end to fulfill that need. We're literally just trying to place them in the community with the existing organizations that we have. And I'll make a point on that. Technology, again, and I'm not anti-technology, but we might be asking a church that doesn't even have a Wi-Fi, that does food pantry in the back, to suddenly log into a system and communicate with us. Well, that's just not who they are at the moment. Different from a multi-specialty group practice that lives in an EHR and has a computer screen in front of them all day long. So there are those limitations with technology too. Even just using tablets, there's a concern with infection around tablets. Who knew? There's a concern that the tablets will wander away. That could happen. So it's clunky, and we're trying to get our way through it. I also think about face-to-face. Like, how do you have these vulnerable conversations unless it's face-to-face? So that's an interesting topic in and of itself, I think. Because a lot of this is relationship forming. Are you ready to tell a screener, that you have these vulnerabilities, or do you need to know who that person is? Again, tons of challenges. We're getting really good at figuring out what doesn't work, and it's just no pain, no gain. It's not a criticism.
We have time for one more question. Does somebody have another question?
So I have one more question, actually. So I don't know if this is in effect yet. I'm just curious to know. So I heard it on NPR the other day that, as we know, Obama administration especially Michelle Obama, was really interested in healthy food lunch, school lunch rather, and they made a requirement CHIP and food stamps, food programs, to be administered through centers. Essentially, you couldn't go to just regular Quick Mart and use the money, because there you could buy, let's say, dry beef or chips or onion dip and stuff like that. So not considered healthy. What I heard that recently the current administration is changing it and saying, look, the Quick Marts are saying we can't hold almond milk. People are not buying it. It's too expensive. If they want to buy whatever they want to buy, whether it's chips or dry beef, so be it. This kind of plays counter to what you're talking about, which is where you want people to have healthy lunches, and you don't want Pepsi in the school system or Coke, whatever it is. So have you heard anything on that, and how is it changing what you're trying to do?
I mean, it hasn't really trickled down yet to this, but that is a fundamental issue, I think, that exists now, even prior to this. When I think of the 150 million, that sounds like an awful big number. And when you talk to these community benefit organizations, $5,000 is a huge number. So I think, we will continue to sit on this scale of trying to figure out, asking and trying to help versus the resources to actually provide the help. And it factors into all those things that you mentioned. We haven't really seen, transportation is big with us. That's come up a lot. Housing usually comes up, but it's not necessarily with everyone, obviously. But those issues are extremely challenging. We've had a lot of just people can't pay their bills. That's come up a lot as well. And quite frankly, we have a tremendous amount of just confusion over how to access healthcare, which is, again, another underlying challenge, I think. So there's, I think we have about 30 things we're trying to fix. This might be one that we're trying to fix, but it's a great point.
Our time is up. Thank you all so much.
Thank you.